Hey guys, like Erin said, my name's Lindsey Jennings. I'm an emergency medicine physician at MUSC, and I was one of the MRDA awardees and just submitted a K back in June. And I'm excited. I'm going to get my scores back at the end of October, so anxiously awaiting those. But I wanted to share with you today some of the work that I've been doing, specifically related to opiate use disorder for patients that we see in the emergency department. So to just give you guys some background, we see a lot of patients with opiate use disorder in the ED, both for complaints related to opiate use disorder, whether that be overdose, abscesses, endocarditis for our injection users. And we also see patients for kind of not necessarily directly related reasons, things like MBCs or completely unrelated people that come in for, a multitude of other complaints. So, we saw there was over 51 million drug-related visits to EDs back in 2011, and that number is continuing to increase. So for our patients that we identified in the emergency department with opiate use disorder, the standard of care used to be that we would just give these patients a referral for outpatient follow-up. And once those patients got actually to outpatient follow-up, one of the gold standard treatment for opiate use disorder is something called medication-assisted treatment. So that is a combination of some sort of psychosocial counseling or intervention. That part of it's pretty vague, but it also includes one of three medications, which is buprenorphine, methadone, or a long-acting naltrexone. So when we were sending our patients from the ED to treatment, we were hoping that our patients would actually be getting medication-assisted treatment. Now, that being said, there's significant barriers. There's a really insufficient capacity for MAT across the United States. So being able to refer to somebody to actually get MAT is also kind of another barrier to getting these patients into treatment. But with the opiate epidemic continuing to expand, emergency medicine in general as a specialty has been trying to figure out how we can better serve this patient population. So there was a big study that was done at Yale in 2015 where they actually took patients and randomized them to one of three groups. So the first group was just a standard referral like we'd normally been doing. The second group was a referral plus a brief intervention. So there's something called SBIRT, which is screening, brief intervention, and referral to treatment. That's something that's been primarily, initially was validated in primary care settings and has since been validated in the emergency department. And so it's a validated screening tool plus a brief intervention, which is like a motivational interview to kind of assess where the patient's at, meet them where they're at, try to maybe move them in terms of wanting to get into treatment, try to move that needle as much as we can, and then helping them with what we can at that point. And then the third group that they had referred patients to was referral, brief intervention, and then actually getting dosed with buprenorphine or getting a prescription for buprenorphine from the emergency department. And this was a huge change in terms of what we actually did in the emergency department. Buprenorphine is more regulated than other medications, and you actually need to have a special DEA license to be able to write for it, and has traditionally really only been used in addiction treatment settings where you actually have people that are board certified in addiction. So this was a big change and kind of a bold move on their part. But what they found was that patients who got buprenorphine from the emergency department actually had much higher retention and treatment rates. So you can see here, I don't know if you guys can see my arrow or not, but this is the referral group here. And so you can see it was like 38% of patients who were just given the referral in the emergency department actually went to that referral and then were retained in treatment at 30 days. But if you take a look at the patients who actually got medication for opiate use disorder from the ED, it was over double. So almost 80% of patients were still in treatment at 30 days. So that was a huge jump. And we know, like I said, that medication-assisted treatment, which includes buprenorphine, is one of the most efficacious treatments that we have for opiate use disorder. So it was really a great outcome that they were able to get these increased retention and treatment rates. So, like I said, I'm down here in South Carolina. So back in 2017, we actually got funding from our Department of Health and Human Services to actually start ED buprenorphine programs across the state. So the first one was at my hospital at MUSC. That was December 2017. And then since then, we've rolled it out at 3 other hospitals and are continuing to working on expanding the service across the state. So You can see here we've inducted 73 patients. This was through June of 2019. 73 at MUSC, 127 up in Myrtle Beach at Grand Strand, and then some smaller community hospitals for a total of 315 patients. And then if you look at our 30-day retention and treatment rates, it varies a lot by site. You can see here at MUSC we're around 70%. We have issues with transportation and distance between MAT-capable providers for the other sites, which has made it a little bit more challenging. But overall, the program has been going really well. It's been well received. And it's actually interesting. Our first patient that we ever started back in December of 2017 is still in treatment. We've had a lot of good success stories of pregnant patients and several other patients who have made it into treatment and are now doing much better, which wouldn't have necessarily been the case had we not had this program available. So, I was in charge of this program doing, everything was going great. But there's been a big push looking at how we can continue to fund these programs going forward. Once the state kind of backs out on some of the funding, can we look at a model where the hospital helps pay for some of this? We're looking at different reimbursement rates and that type of thing. So I was, I guess, a little bit surprised that I just showed the hospital kind of our numbers so far that they wouldn't want to continue funding. And that's kind of what sparked my interest in doing a cost analysis and utilization analysis for these patients. And that was one of the primary aims of my K. So we've done a couple kind of small prelim studies. So our first one that we did was back in in June of 2018. We collected all of our patients at MUSC between December and April. And at that point, we had only inducted 27 patients. We did a chart review going back and looking at all ED visits and admissions 30 days before induction and 30 days after. And went ahead and did the same thing we have an electronic health exchange that gives us the rest of the information for all the other hospitals in the county. And then went through and added all those up. So we had 8 for all the patients, 8 ED visits total in the pre-group 30 days before, and 1 ED visit in the post-group. And then we had 2 admissions pre and 0 post. So then we were able to assign expected payments based on reimbursement data from our county from 2017. And we were able to get charges and expected payments. And then we kind of added up the pre, added up the post, and then just divided by the number of patients that we had, which was 27, and found there was over a $700 reduction in expected payments per patient that had this intervention over a 30-day period. So these results were really promising, and we were really excited about this. And we've continued to kind of monitor as we go forward. We did a more recent analysis without adding the cost component yet, just looking at utilization. And so at this group, we had 43 patients, did similar workup in terms of looking at emergency department visits at MUSC and then the other hospitals in the county. And then we're actually able to classify the ED visit as related to opiate use disorder versus not, based on a set kind of standard group of ICD-10 codes. And then did a McNamara's exact test. The reason we did that was because with the small sample size, the data we couldn't assume was normally distributed. But what we found is that there was a statistically significant reduction in opiate-related ED visits when patients were actually on treatment as compared to those who did not get this intervention. Compared to those who did not get the intervention, and then looking at we also looked at all-cause ED visits and didn't find anything statistically significant there yet, but again, a small sample size. So where we're looking at this going forward, we are going to take from all of our sites, so we'll have more patients, get those patients' identifiers, send them we have a state all-payer database, which will give us all of these patients' ED visits, admissions, throughout the whole state, and this tends to be a transient population, so it can be difficult to really track these patients. So we're going to be looking at that and looking at their charge data and expected payment data, and so we're really excited to get that kind of more robust analysis going, so we can demonstrate not only the value to our patients, but demonstrate the value of this project in terms of reducing healthcare costs and acute care utilization. So I actually just got the first data for that poll last week, and it looks really promising. We actually had, just looking at all patients in South Carolina who had had an ED visit for opiate use disorder to an ED. We actually were able to pull all of their utilization, and we have several patients that are actually utilizing either inpatient admissions or emergency departments over 500 times a year. So being able to link these patients to treatment, and if we can get them sustained in treatment, we have a big potential to actually reduce that and reduce acute care utilization, which in my hope would maybe help us get some funding to continue these programs going forward, if we can provide these patients with this service and get them, one, in better health shape for them, and then two, reducing acute care utilization, so that we can continue these programs going forward. So. Any questions or anything? Sorry, I know that was fast.